Today's topic of discussion will be on hemophilia, its various types of treatments, and the questions scientists have been asking themselves for years. Will there ever be a cure?
So what is hemophilia?
The very first evidence of the condition dates back to ancient Egyptians, but hemophilia became more widely known when it inherited the nickname the royal disease, after Queen Victoria transmitted this illness to her descendants in the 19th century. The word hemophilia can be broken down to form two separate words. Heme, a red pigment containing iron and other atoms to which oxygen binds to, and philia, meaning love or affection. In other words, hemophilia is a hereditary condition passed on from a mother to her child at the time of conception and affects around 6,000 people in the UK.
Essentially, people with hemophilia lack a protein necessary for normal blood clotting, which is a process that occurs to prevent excessive bleeding when a blood vessel suddenly becomes damaged. This is due to a mutation in the gene located on the X chromosome, responsible for providing instructions for making the clotting factors required for the blood clotting cascade. These proteins would otherwise usually form a cross-linked fibrin mesh in the vast majority of people, signaling the end of the blood clotting process. As a result, the mutation can prevent the clotting factor from working properly, or in rare cases, from being present in the blood altogether. In addition, the fact that the gene exists on the X chromosome means that men are more likely to have the condition than women, since males only have one copy of the gene, whereas females have two. There are 12 clotting factors in total, but mutations in clotting factors 8 and 9 cause two different versions of the condition, hemophilia A and hemophilia B, respectively.
So, what are the treatments for hemophilia?
Treatments, however, have been discovered for both hemophilia A and hemophilia B. There are two main approaches: preventative treatment, where medicine is used to prevent bleeding and subsequent joint and muscle damage, and on-demand treatment, in which medicine is used to treat prolonged bleeding. They both, however, appear under the umbrella term prophylactic factor replacement therapy, or simply prophylaxis. Since different clotting factors are affected, the treatment for hemophilia A isn't exactly the same as the treatment for hemophilia B. The two share some similarities.
Those with hemophilia A require preventative treatment. Regular injections of Advate containing the active substance octacog alpha should be taken. Likewise, for patients with hemophilia B, Benefix containing the active substance ononocog alpha should be injected regularly as well. According to the European Medicines Agency, both are available as a powder and solvent that are mixed together to form a solution for injection. Advate and Benefix are also used by doctors to correct deficiencies in factor 8 and factor 9 respectively, whilst providing temporary control of the bleeding disorder.
Both medicines are produced using recombinant DNA technology, in which a target gene responsible for producing the specific clotting factor is inserted into a plasmid, followed by the newly formed recombinant DNA being inserted into bacteria during a process called transformation. As a result, multiple copies of the gene form, since bacteria are able to reproduce very quickly, thus enabling more of the medicine to be produced.
Patients requiring on-demand treatment are usually those who require treatment as an immediate response to bleeding, although these cases generally trend to be mild or moderate. Here, patients with hemophilia A could once again be injected with octacog alpha, although other medicine that doctors often prescribe is desmopressin, a synthetic hormone which also stimulates the production of factor 8. Patients with hemophilia B are still given nonacog alpha for both forms of treatment.
Despite the proven effectiveness of the treatments, there are still certain complications which can also reduce the effectiveness of the medicines. Some patients may develop inhibitors, which are essentially antibodies against the blood clotting factors, causing medicine to become less effective. However, this can be treated with the immune tolerance induction, also known as ITI, which is usually given to patients with severe hemophilia A. The patient is given daily injections of clotting factors, and in this way, the immune system is encouraged to recognize the blood clotting factors and stop producing inhibitors. For patients with hemophilia B, ITI could be offered, but generally speaking, the medicine is less effective and is likely to cause severe allergic reactions instead. Meanwhile, patients with mild hemophilia A who experience inhibitor development are treated with bypass therapy or immunosuppressants. The former uses a medicine called a bypass agent, which effectively stops any bleeding, whilst the latter reduces the immune system's ability to reject the clotting factor.
Another complication, often associated with hemophilia, is joint damage. This takes place when joint bleeds cause damage in the cartilage, which is soft tissue, and the synovium, the thin layer of tissue lining in the inner section of the joint. As a result, the greater the damage in a particular joint, the more vulnerable it is to bleeding, which can subsequently cause progressive damage, arthritis, and pain. In particular, bleeding in the head can cause seizures or paralysis, which could be fatal if uncontrolled. In general, joint damage is more common in adults and the elderly with severe hemophilia, and it is believed that with the current and predictive improvements in modern treatment, the youth growing up with hemophilia today are almost certain to never experience joint damage in their future. Nevertheless, patients with joint damage require surgery to be treated. In some cases, damaged synovium can be removed in order for new synovium to grow. Whereas, if a patient suffers from serious damage, joints may have to be replaced during treatments such as hip replacements and knee replacements.
Now we'll be looking at the latest scientific progress with hemophilia, including the controversy around whether there will be a cure.
Hemophilia is indeed a genetic disorder. Since a random mutation occurs in the gene responsible for producing the clotting factors required in the blood, as a result, many body systems are affected due to the gene mutation existing in almost every cell in the body. And so it is difficult to develop a cure for hemophilia, as genes cannot be altered in the body easily. In addition, it is not exactly possible to replace the mutant gene in each cell in the body, primarily because the mutations are occurring all the time, but also due to the impracticality of the task. Therefore, at present there are a wide range of treatments for hemophilia, but no individual cure.
Previously, there have been some cases where a small number of patients with hemophilia had received liver transplants, since the clotting factors are made here. However, transplants are often disregarded as a viable option by doctors simply because of the risks they carry. For example, there is likely to be a degree of rejection by the immune system, which could cause the body to attack the new liver. There may also be the possibility of graft failure, which is where the liver doesn't work as expected, as well as the potential blockages or leaks in the bile ducts. Other issues may revolve around the side effects of the immunosuppressant medicine taken as part of the transplant, as this could lead onto an increased risk of infections or even kidney problems, according to the NHS.
However, a recent intervention for hemophilia currently being explored is gene therapy, which works by providing patients a new working copy of the genes for either factor VIII or factor IX. The main goal is to insert the genes into cells in the body that are capable of producing genes. For this, it is believed that the most suitable organ is the liver, At the Hemophilia Treatment Center at the University of California, Davis, all the hemophilia gene therapy trials are using a virus called AAV, adeno-associated virus, to help insert the gene into the body. Dr. Jonathan Decore, director of the treatment center, explained that AAV types used are ones which go to the liver and insert the gene into the liver cells. Unlike other viruses, AAV doesn't divide and has not made any trial patients sick so far. Likewise, the virus is not believed to interfere with the liver genes, and therefore, the vast majority of researchers predict that the risk of severe liver damage or cancer is very low.
Trials are also being undertaken at the biotech company BioMarin under the supervision of Dr. Stephen Pipe, chair of the Medical and Scientific Advisory Committee of the National Haemophilia Foundation and lead investigator of the clinical trials of the company. He previously confirmed that trials have been successful and the patients who had finished their prophylactic factor replacement therapy as a result have since experienced dramatic reductions in bleeding, many with complete cessation of bleeding. In particular, the levels of clotting factor are believed to be within close range of the expected levels for factor VIII and factor IX, especially in recent trials. Some are even still showing persistent expression despite approaching almost 10 years since their treatment, indicating that gene therapy could be a durable, if not lifelong, correction for hemophilia.
Despite the promising results, there are certain issues associated with this modern treatment. First and foremost, gene therapy only provides a clinical cure, but does not actually correct the initial mutation, meaning that the chances of genetical inheritance in successive generations is still the same. These trials have also been going on for a relatively short amount of time, and so it is uncertain as to how long the clotting factors will be produced in humans post-treatment, despite studies showing that production lasts for decades in dogs. Furthermore, trials are only being conducted for patients aged 18 and over, so researchers aren't sure if the therapy will necessarily work on young people, especially since the growth of the liver is greatest at a young age. Finally, there is the ethical dilemma. Who can access the gene therapy? Since the treatment is fairly new, it may take scientists another 5 to 10 years to completely understand the effectiveness of the treatment. And until then, it may be that not everyone with hemophilia can benefit from this potentially life-changing treatment.
100 years ago, patients with hemophilia were deemed to have a short life expectancy, but with the rapid medical advancements that have come with much improved technology, patients with hemophilia are gradually beginning to feel more optimistic about their futures. With this in mind, we would like to leave you with the following quote from Elon Musk: when something is important enough, you do it even if the odds are not in your favor.
Thank you for listening. Also, make sure to like, comment, and subscribe, as we will be bringing out more episodes in the future. Thank you.